And now we invite Dr. Vineet Sehgal, who would be talking about the ocular blood flow analysis in clinical scenarios with some interesting cases.
Thank you, ma'am. Thank you, Balla sir, for providing me this opportunity. So the topic that is assigned to me is evidence in favor of role of ocular perfusion pressure. So as sir has told, we have color Doppler imaging, we have OCT angiography right now in our armamentarium, which we are doing it in our clinical scenarios. Various institutes are also having access to OCT angiography, and our radiologists, they are doing regularly carotid Doppler. So with the small amount of training, now they are also doing the ocular Doppler. So I would be talking about these two as my evidence for the ocular blood flow analysis. Uh, we have highlighted uh, in our previous sessions that yes, the vascular theory basically makes sense. So if I basically tell you here that yes, internal carotid artery is the main artery which supplies the eye, it gives rise to ophthalmic artery. Ophthalmic artery has then two branches. One is your central retinal artery, and the other relevant artery is the short posterior ciliary artery, as you can see here. So this short posterior ciliary artery, central retinal artery, and the ophthalmic artery, these are the three arteries where we should basically have our focus to know what is going on in the optic nerve head. So now in my practice, in my clinical practice, in which patients should I go for a ocular blood flow analysis? First of all, as we have mentioned here, the patients who are having glaucoma, the subset of the patients who are having a normal tension glaucoma, or those patients where even after control of intraocular pressure, now we have the intraocular pressure in the target IOP, if still they are progressing, that is an indication for doing a ocular blood flow analysis. The second subset of patients who are having ocular ischemic syndrome, because we all know that the internal carotid artery would be basically affected there. Then the patients who are having vessel occlusion like central retinal venous occlusion, central retinal artery occlusion, that our retina colleagues are seeing day in and day out, definitely it can have a role also there. And this is my favorite indication, sir, detecting underlying undiagnosed systemic comorbidities in the patient with the ocular history. So the patient comes and he says, after getting a femto laser cataract surgery with EDOF lens, now he says that, sir, I am not heavy, sometimes I get some visual blurring, and we basically diagnose him, it can be some meibomitis or something like that, or there can be amaurosis, and he is referred to the glaucoma clinic with a 21-22 IOP. And we did an ocular Doppler and we saw that there is something else which is going on. This is not a functional complaints. So my protocol in my OPD, patients, as I told you, who are glaucoma, NTG patients, then what I do is I basically go for a 24-hour BP monitoring in these patients. So if there is a diastolic dip there in the night, or there is a variation in blood pressure, definitely, as ma'am and sir have told this would definitely affect the ocular perfusion pressure. So basically, now it comes that the theory is coming into clinical practice. How we can basically assimilate all what sir have told us in our clinical practice. We have to basically tell the patient to get a ambulatory BP monitoring. And then we basically do a ocular blood flow analysis. We send the patient to a radiologist and then to the cardiologist. So we should have a triangle here. The triangle consists of one ophthalmologist, the second radiologist who is doing the ocular Doppler, and third the cardiologist. Because we have told here that yes, vascular component takes a very important role. So um, as sir has told us about color Doppler imaging, I won't go into too much of practical details. Again, the same thing, ophthalmic artery, central retinal artery, short posterior ciliary artery. Sir have told us that yes, there are few parameters we have to basically see. So that is my better half, Dr. Anchal, who is doing a Doppler, ocular Doppler in a patient, and not going into too much of the techniques, as you can see. Now, earlier what was told was that actually this is all in the concept. We practically are not doing too much of ocular Doppler, and if we are doing ocular Doppler, we are not getting good waveforms. So I can just show you that yes, there is evidence, sir. You can see here that we are getting very good flows. So yes, it's everyone, those who have access institutes or those who have friends in the radiology department, yes, you can get good flows of the central retinal artery as well as of the ophthalmic artery, as you can see here. So these are repeatable structures like a visual fields we do, and in visual fields there is something which is called a reproducibility. Similar reproducibility we can get in our ocular Doppler studies as well. So I would not say my experience, I would say my learning. So I am doing it for almost all subsets of population. There are 3 studies with 3 theses which are also going on in Safdarjung Hospital. And whenever we do give a OBF report, it's a very important thing is we just do not have to see the parameters, also see the experience of the radiologist, what he or she thinks when she is doing it. So we write here impression. Now what is the basic aim of writing the impression? I would just show you here. Okay, so there are, as sir has told us, there are different type of waveforms of ophthalmic artery, central retinal artery, and short posterior ciliary artery. Now, why they make a sense that I would be talking about in my first case. So this was a 74-year-old gentleman, pseudophakic in both eyes with baseline IOP of 21 millimeter. After getting a cataract surgery, he says that, sir, I am not very happy with the cataract surgery. My quality of vision goes down sometimes, then it is okay. He was just a hypertensive, a controlled hypertensive, nothing else. There was a small pale disc, almost normal type of disc. We did all types of tests, visual fields, OCT, DV, everything seems to be okay. I think this was way back in 2017, 2018, sir, when I started this ocular blood flow analysis in few of my patients. I sent the patient to the radiologist, and I just got a call in my OPD that something which is not very regular that is coming. As you can see, these are the normal waveforms. These are the normal waveforms, and see this red area, you are getting some abnormal waveforms. Now what to do? We are getting some abnormal waveforms here. So my radiologist told me that, okay, I am doing a ocular Doppler, let's go for a carotid Doppler as well. And now you see, in the carotid Doppler, you are getting 100% blockage of the internal carotid artery. So what might be happening here is some collaterals which are now forming around the optic nerve head, which are basically causing these aberrant waveforms. So the patient came with the ocular history, and we got something which is more important in terms of his vascularity here, and the patient was referred to the cardiac department. This was a case 2 where a 75-year-old young gentleman came to the OPD with a similar kind of complaints after getting a cataract surgery. There was a baseline IOP of 24 millimeter of mercury, ocular hypertensive, everything was almost okay. OBF analysis and carotid Doppler was done, and then the patient was sent for cardiological evaluation. So what are the findings in the color Doppler? In the color Doppler, the SPCAs, the short posterior ciliary arteries. Now I tell you that normally what happens is the ophthalmic artery and the central retinal artery, these waveforms are basically seen easily, but sometimes the short posterior ciliary artery waveforms are not seen even with the effort. So 2 or 3 times it was tried to get some SPCA waveforms, but not in the nasal or not in the temporal side. We are not getting any of the SPCAs. The carotid Doppler was done, and there was a blockage. The patient was sent for the cardiological department. I always complete a triad here. So the patient was sent here, and then it was seen that there is a stenting was done in the patient, and the patient again was basically sent to the radiology department for the re-ocular Doppler. And when we did the Doppler again, we saw that there is some blood flow we are getting in the short posterior ciliary artery. So the hypothesis is that after basically we improved the flow in the internal carotid artery, now some flow can be directed in the SPCA. Now this is the first time, not in the literature we have basically seen this, but the problem is that the patient is still having the same symptoms. Patient still says that I am having the amaurosis fugax, I am getting blurring in vision sometimes. There is no change in the clinical symptoms. So definitely these all, whatever we talked about, the OCT angiography, the ocular Doppler, these are some expensive techniques, and you need a reproducibility trained radiologist, And definitely costly machines, the ocular Doppler and the OCT angiography, they are costly, and we do not have long-term data and the normative data right now. Sir, can I have 1 minute, please? Okay. So I basically end my slides with this one, that whatever we do OCT angiography, we do ocular Doppler, there we should go ahead with the validation and calibration of our technique, how to do it. Like visual fields, we do basically train our interns, our optometrists how to do it, to assess in which of the patients the ocular blood flow can be compromised or decreased, then to assess the usefulness of any intervention, whether we give any drug or we go for any cardiological intervention, can it increase our ocular blood flow? And the last but not the least is that if this ocular blood flow is even increased, can it lead to any decrease in the progression of glaucoma? That is the question still needs to be answered. Thank you very much again, sir, for giving me this opportunity to present these cases in front of you.
Thank you, Dr. Vineet, for a very interesting and a very clinical